Okay, Representative Lavender, I apologize. I've been missing you all day.
I know,
You're
and I
recognized for
moved up here
inquiry.
just for you. Thank you, Mr. Chair. To continue to beat a horse just a little bit, perhaps from a perspective of a physical therapist, disability is not a clear-cut line. So not referring to anybody who's disabled today in any capacity, but tomorrow, if somebody has a back injury, a knee injury, they fractured a leg, they're able to work comfortably at 20 hours a week, they may not qualify for health insurance anymore. Their level of income may be at 138% of poverty or less. Those people are the ones who would be able to qualify for Medicaid expansion to have health care without losing the opportunity to work 20 hours a week. So it is not the people who are disabled today, and it's not the person who falls, breaks their neck, and is a quadriplegic that will be determined fully and permanently disabled. So there are a lot of people that have health issues that may prevent them from working a full-time 40-hour week job that has health care, that are the people that we're now going to have the opportunity to include in this Medicaid insurance versus looking at permanent total disabilities. So to clarify that, I hope perhaps a little bit for how there will be a difference of a different door. If I have the opportunity to have insurance, I'm not going to pursue total permanent disability because I still do have the opportunity to work, but just at a lesser capacity than I might have had before. So if I can, I'm going to now go to some other questions, things that I don't think we've really had the chance to cover here yet today at all. So one of the savings that we get by expanding Medicaid is in regard to mental health, substance use disorder, or incarcerated populations. Is that accurate?
I believe it is accurate that that would occur, but we did not include it in our fiscal note
All right,
analysis.
so that's even additional savings that the Health Management Association feels is to us that you have not even included into your summary or your fiscal analysis of the expansion.
That's correct, Representative Lavender.
So we've talked about now permanent partial or permanent total disability and how some of those people, and you said 5% is the number that you took into your analysis that produced savings for the program.
You're talking about the 5% growth rate or the permanently totally disabled?
The permanent total disabled. Did you tell me it was a difference of 5% earlier?
Yeah, so if you look at our report, we walk through how we got to that 5%, the attrition rate over time. Yes.
Right. So that's where some of the savings are. Some of the things, and I apologize, Mr. Chair, I think Remy might be coming, but I think another thing that you didn't even include in your analysis was the growth opportunity of our state. So we have the opportunity to increase employment growth beyond healthcare by 79%. Inside of healthcare, I think 63%, 16,000 new jobs created each year, 79% not in healthcare, $2.5 billion in economic increase. So now we'll get more income tax because more people are working. 64% of the jobs aren't in the urban areas. So these are now rural jobs. They're going to be good paying jobs. So now we have people employed that are going to be paying income tax to the state of Missouri. You didn't include that in your analysis?
Yes, Representative Lavender, we did not include that because we were not asked to include that. Our charge was only to look at the Mo Health Net budget, period.
Right. So where your analysis shows that this is potentially revenue neutral or will save Missouri money, you haven't even included the job opportunities that are going to come to our state because we're going to expand Medicaid.
That's correct.
Right. And then I'm going to backtrack just a little bit. Your background, you're a PhD in economy?
PhD in economics from the University. Yes. Mm-hmm.
And so you bring 30 years to the table, did I hear you say earlier also?
Yes, sadly, over 30 years, yes.
I know. I've gotten more. I tell people over 30 years myself. It works, right? So you're bringing a background to this that we've not necessarily heard presented from other people today.
I won't speak to other people today, but I appreciate your kind comment. Thank
All right, and then how many different studies did you look at that you included in your analysis?
So that's a great question. We looked at, we cited them in our study. There's, I think, 20 or so footnotes, but I think that's an underestimate of the number of places that we looked at. There were questions about the number of states that we looked at. Frankly, we looked hard at 8 or 10 different states. Illinois, Ohio, Indiana, Arkansas, Washington, but we also looked at a CMS report that looked at all the states, expansion versus non-expansion states, and to look at the data there. And we looked at the peer-reviewed literature, and there's a substantial peer-reviewed literature that looks at expansion versus non-expansion.
And where I don't necessarily appreciate being perhaps the 38th state that expands, I think we've missed an opportunity. It sounds at least there is now ample information that precedes us that demonstrates that this is successful for states, and there's no reason to think that we're not going to be able to be successful in that as well.
Correct.
Again, I'm going to go back to the American Hospital Association's report, pardon me if I said that right, Health Management Association, pardon me. We're going to be able to include additional veterans onto these programs and these various different structures. I want to reemphasize that this is a statute in federal government that is the 90-10 match.
Correct.
This isn't the whim of anybody in Washington, D.C. to decide to stop this program.
Yeah, the 90-10 match could not be overturned by the regulatory change by the president, or it has to be a change by the Congress signed by the president.
I heard earlier that Missouri was very generous in the Medicaid population that we have today. We cover people at 19% of poverty rates. It doesn't occur to me that we're generous. Were other states at a higher percent of who already qualified for Medicaid before they expanded?
So, if you look, just speaking as a researcher on this question, we are among the lowest states, if not the lowest, in terms of eligibility level for custodial parents. You're right, it's about 19-20%. We have been historically very generous for children. We were one of the first states to expand eligibility up to 300% of federal poverty line. I think Governor Bond pushed that through, and so there's an historic pitch to take care of children, which I'm pretty proud of in this state. We never have covered single people, single males, single females, or married couples. They're just not eligible. They're in that gap population. The disability population, as you heard, is about 85% of poverty.
I brought this up in budget earlier this year on this floor, so after COVID, that I don't think there's a definition, state or federal, of what an able-bodied individual is. So I agree with you, single adults do not qualify in any capacity. I've met, maybe you've met, people that have been successful, productive people in society that have health insurance and then get a debilitating illness or disease. Cancer prevents them from working, prevents them from having access to health care, and then as a state, we literally have no coverage for them. This expansion would allow them to have coverage of health care if those were the circumstances that they ran into.
That's correct.
Right. IT, I believe IT has always been covered at 90% if we were going to expand.
That's correct, Representative Lavender.
And then most states have found that this does not lead to substantial decrease in spending of state funds. So we've heard amply that this is going to take from education, it's going to take from transportation, but other states have not found a decrease in spending in these other areas. Is that part of your analysis as well?
Yes, I would agree with that, and I would the point that was made earlier, no state has reversed its Medicaid expansion, is really important. And to your point, there's a study that, the legislature may want to look at from June 11th in the New England Journal of Medicine that speaks to this point and has really excellent data about how, and they did a thorough analysis of all the states and show that, if I could quote, if you don't mind, we found no evidence that Medicaid expansion forced states to cut back on spending on other priorities such as education, transportation, or public assistance, despite frequent assertions that would happen.
Right. And yet we want to make sure that we teach our citizens to be fearful of health care because it might cut education, and yet that has not been the result in any other state that's expanded.
Right.
So this might be wishful thinking on some of us on the floor today, but the United States Congress is talking about an enticement for those states that haven't expanded yet to take that back up to 100% for whatever length of time that may be. That certainly would be in our best interest. I would think you would agree. I know. Is there anything else that we haven't specifically talked about today that you do feel would render savings in the program that we haven't talked about?
Well, it's been a long day, and we haven't talked about, we have talked about the savings outside the MoHealthNet program, the mental health. We haven't talked about corrections, and I think that's worth mentioning. And to the credit of DSS, and again, I was digesting this on the fly. If I read their spreadsheets correctly, they have savings in there for corrections, and I think that's worth pointing out and worth you all thinking about. While I was on the oversight committee, that point was brought up, is, some people in our prison system could end up becoming new Medicaid eligible. As I understand it, the health care that would be provided in the prison would be the responsibility of the correction system, but if they go outside, if they're Medicaid eligible, that could be a 90-10 match. So that would be considered helpful to the state. And it came up in an oversight committee meeting. One of the senators brought up, could we expand Medicaid just to the prison population? We can't. The federal government's never allowed that. But if we expanded Medicaid, then the corrections population would be rolled in. And so that's another place where savings would come in place.
Good. And then just to re-emphasize, and I've had the opportunity to go on to yours, was it the analytical graph? What do you refer to that as? Where you can change the parameters?
Oh, data visualization.
Data visualization. So I believe you have 3 or 4 parameters that can be altered on that data visualization. Is that?
That's correct. We allow people to adjust the per member per month. In our fiscal analysis, as you know, we have that ranging from about $350 to $500 per month. We allow you to adjust the growth rate in spending. We allow you to adjust the take-up rate that Representative Smith and I were talking about earlier. If you don't believe our 73%, you can raise that higher. And I forget, there may be another one. But and those are, go ahead.
Well, for people here, on page 8, I have of your policy that I think we were handed today. I think that at least is what your analytic, I forgot already, analysis allows us to do is it changes the numbers that you can see how those categories of expenditure, whether it's children, pregnant women, disabled, you get to see by changing your numbers how that changes the payout of the state. And even as we went through and perhaps more people joining because of the unemployment with COVID, it still did not alter that this is very likely to be revenue neutral in our state.
That's correct. In that visualization, you could raise the number of people that could become eligible to over 300,000, and it's still budget neutral.
I don't know that you heard earlier, it was talked about that some states have a poison pill in their Medicaid expansion legislation. And we talked about how difficult it was that we weren't going to have that. Medicaid expansion was available to us as a state 10 years ago. Is that correct?
It was passed in 2010, and the Affordable Care Act of 2010 could be implemented in
And then even if we
2014.
waited,
Yeah.
right, I think it was in 2012 that the United States Supreme Court said Medicaid expansion could be optional,
Optional, yes. It was required in the original
right?
legislation.
Then we're going to say there were 8 years that this chamber had an opportunity to pass legislation that could have put a poison pill in it. So for us to complain that the ballot language doesn't have that in that, well then shame on us for not putting that in there, that the people of our state finally spoke and said we'd like the opportunity to vote on this. It occurs to me, with your analysis and what you've provided for us, it shows that Medicaid expansion saves Missouri money. It helps our neighbors, it provides health care. I'm not sure why we want to do this as a state for the people who live here. Thank you for testifying. Thank you very much, Mr. Chair.